pit and fissure sealants. The caries process is multifactorial and over time can culminate in localized destruction of hard dental tissue by the weak acids produced by bacterial carbohydrate fermentation. Microbial shifts within the oral biofilm upset the balance of tooth enamel remineralization or demineralization process, and this balance is also affected by salivary flow, composition, fluoride exposure, consumption of dietary sugars, and preventive behaviors like brushing the teeth. Whether the dental caries progresses, it is halted or reversed depends on the balance between the above said protective and pathogenic factors. The anatomic grooves or pits and fissures on the occlusal surface of the molar teeth can trap food particles and promote the presence of bacterial biofilm on the above said surfaces, thereby increasing the risk of carious lesions. And there are four types of fissure anatomy. One is the V type, another one is U type, I type, and IK types of fissures. Among these, the V and U type are susceptible to initiation of dental caries lesions as it is almost self-cleansing. On the other hand, I type and IK type are more susceptible to dental caries when compared to the other two types of fissures. When it comes to prevention of dental caries, the usually used strategies are use of topical fluorides and meticulous oral hygiene. Problem with brushing is that when the fissures are deep and narrow, the bristles of the brush is unable to clean the depth of these grooves or fissures. So the bacteria will have an undisturbed niche, allowing the caries initiation and progression. Apart from the usage of fluoride and regular oral hygiene, one of the most important prophylactic approaches against the occurrence of caries is to seal the susceptible pits and fissures. The susceptible pits and fissures is penetrated with an inert plastic material so that there won't be any accumulation of food debris and further inhabitation by the bacteria. Effectively penetrating and sealing these susceptible surfaces with a compatible dental material can of course prevent the initiation of caries lesions, and it will be a part of comprehensive management approach. From the perspective of secondary prevention, the sealants can also inhibit the progression of a non-cavitated caries lesion. So the use of sealants to arrest or inhibit the progression of caries lesions is important in determining preventive strategies. These dental sealants act as a physical barrier to the accumulation of debris and bacterial proliferation. The materials that can be used as sealants can be broadly broken into two main categories based on the type of reaction that takes place as they set in the mouth. The main two categories are one resin-based sealants and the other one is glass ionomer-based sealants. Glass ionomer-based sealants undergo an acid-base reaction while they set, whereas the composite resins set through a polymerization reaction that is usually initiated by a dental curing light. Resin-modified glass ionomers and polyacid-modified resins are also available for use as sealants, and they set by a combination of the above said two reactions. And all these result in sealant products with differing characteristics that may vary across a continuum from those of traditional glass ionomers to composite resins. The most commonly accepted material among these are resin-based sealants because they show superior retention rates as compared to glass ionomer cement. And for a material to act as a sealant, the most important property will be its retention to tooth structure. The resin-based sealants can be classified into four categories based on their polymerization reaction. That is, it can be either ultraviolet polymerized, autopolymerizing, visible light polymerizing, or it can be the latest generation be fluoride releasing resin sealant. Based on the color of the material, the resin-based sealant can also be classified as transparent or clear sealants and opaque or tinted sealants. The advantage of an opaque sealant is that it is easy to see both during application of the sealant and to monitor its retention at recall visits. It is mandatory that while application, the sealant has to be extended into all pits and fissures. So only with a tinted or opaque sealant, we can make sure that while application, the sealant material extends into all the susceptible bits and fissures, whereas with a transparent or clear sealant, it will be considerably difficult to achieve this result. And on recall visits, the assessment of a clear sealant or a transparent sealant will require tactile exploration of the sealed surface. With just a visual examination, we won't be able to identify whether the sealant is retained over there or not. But the advantage of using a clear or transparent sealant would be like it will be aesthetic. That is, it will be difficult to differentiate between the sealant material and the adjacent sound tooth structure. And most importantly, any secondary caries lesions develop under the sealant material, you will be able to see it through the transparent or clear sealant. These caries lesions cannot be seen under the opaque or printed sealants. Based upon the presence or absence of filler in the sealant material, it is again classified into unfilled and filled sealants. The unfilled sealants have lower rates of micro leakage and a better penetration into fissures. The theory is that unfilled sealants penetrate deeper into the fissures due to their low viscosity and create a longer resin tracks and therefore better retained. Another clear advantage of the unfilled sealant is that after polymerization, occlusal adjustment is not necessary. That is, due to the lack of filler particles in the sealant material, the unfilled sealant will abrade rapidly even if it is left in occlusion. On the other hand, the filled sealants will require occlusal adjustments. That is, we have to check for high points after application, as the individuals will not be able to abrade the occlusal interferences by their own. And this necessity to adjust the occlusion after the application of filled sealant may increase the time and cost of procedure and may also prevent delegation of sealant placement to auxiliaries. On the other hand, the advantage of filled sealants is that they have better wear resistance and less porosity. So the advantage of unfilled sealant is that they will penetrate deeper into the fissures due to their low viscosity and are better retained. Whereas the advantage of filled sealants will be they are more wear resistant and less porous. So we have to select a sealant keeping all these factors in mind. Coming to choice of sealant depending upon the patient's age and the level of isolation that can be attained. In case of compromised isolation, we have to go for glass ionomer based sealants. Example, in cases like partially erupted molars where the gold standard of rubber dam cannot be applied, it is better to go for glass ionomer based sealants. Later, the glass ionomer sealant has to be replaced with a resin based sealant. And for this reason, glass ionomer sealants are also called transitional sealants. So if we have a satisfactory isolation, we have to go for resin-based sealant. Depending upon the aesthetic demands of the patient or the caries risk of the patient, you have to choose whether to go for a transparent or opaque sealant. And if the isolation is compromised, we have to go for glass ionomer cement. It can be both conventional or a resin modified glass ionomer cement can be used. Type 4 GIC is usually used as used for sealant application. When selecting a sealant material, we have to keep all these things in our mind and to customize our treatment plan depending upon the patient's age, behavior, caries risk and the level of isolation that can be accomplished in a particular patient. So once we have selected the case and selected the material, these steps have to be followed while applying a sealant material. First, the tooth has to be cleaned. There are various methods has been suggested in literature for cleaning the occlusal surface like air abrasion, prophylaxis or like with pumice, cleaning with hydrogen peroxide, etc. But the literature is confusing whether to use it or not. Anyway, the tooth surface has to be dry before sealant application. And when you are using a resin-based sealant, surface that is going to be sealed has to be edged with 37% phosphoric acid. If the tooth structure is sound, application time of 10 to 15 seconds will be sufficient. Fluorous teeth and in primary teeth, the etching time has to be considerably higher. Once the etchant has been in contact with the tooth for sufficient amount of time, it can be rinsed off and the tooth is dried so that a frosted appearance is obtained. Once that is achieved, it can apply bonding agent, dentin bonding agent. Again, the literature is confusing whether to use dentin bonding agent is to be used or not. Dentin bonding agent, if applied, is air thinned and then light cured. Once dentin bonding agent is in place, sealant can be applied onto the tooth structure and spread evenly to the susceptible pits and fissures using a micro brush, or you can use a tip of the explorator. Once it is made sure that the sealant material has flown into all pits and fissures, it should be light cured depending upon the instruction of the manufacturer. Curing time should be in accordance with the manufacturer instructions. Once the sealant is cured, if it's an unfilled sealant, it is not mandatory that you need to check for occlusal interference. If it's a filled sealant, it is mandatory that you check for high points with an articulating paper, and if there are any occlusal interferences, you have to remove it. The patient has to be recalled at regular intervals to check for the retention the sealant and to monitor at regular intervals. Retention of the sealant is the most important criteria for the success of the sealant application. At recall visits, if there is some sealant loss, we will have to repair it off, or if there is entire sealant loss, we have to replace it. Coming to their prerequisites of a material to act as a sealant, the main criteria is that it should have enough flow and wettability such that it will flow in deeper into all pits and fissures, and it will wet the tooth surface. And as it has been stated earlier, that the retention of the material is the major factor that contributes to the success of sealant application. So a material that bonds either chemically or micromechanically to the tooth structure will be an ideal material to be used as a sealant. And coming to certain limitations of the sealant application is that when using a resin-based sealant, it has been suggested that the resin-based sealants contain a compound called bisphenol A that contributes to the electrogenicity. But studies have proven that the amount of BPA that is being released from the sealant application is not substantial in contributing to any side effects. And benefits of sealant application that it can be done without any local anesthesia and can be utilized as a preventive program even from the first dental visit itself, because it is not an invasive procedure, so it can be accomplished even in the first dental visit. Coming to teeth that are indicated for sealant application are the tooth with deep pits and fissures that is susceptible to dental caries. All teeth at any age with the susceptible deep pits and fissures can be sealed with suitable material for the prevention and for the initiation and progression of dental caries. Again, tooth with non-cavitated carious lesions, that is stained pits and fissures on permanent molars, are also an indication for sealant application. That is, even if the caries process has initiated, before the lesion becomes cavitated, you can seal the surface to prevent further progression of the lesion. So deep pits and fissures susceptible to caries process and non-cavitated caries lesions on pits and fissures are ideal candidates for sealant application. Can be undertaken in any children, but children with high caries risk should be done as early as possible, like children with special healthcare needs or children with poor dexterity for plaque control. In such children, even if the pits and fissures are self-cleansing, you can apply sealant for protective benefits. When not to do it, like fissures are shallow and self-cleansing, the sealant application is not mandatory. And if there are any radiographic or clinical signs of proximal lesions and the tooth requires a conventional restoration, better to go for a preventive resin restoration or routine restorations. And again, any sign of pulpitis like pain or sign of apical periodontitis like tenderness to percussion or pathologic mobility, the application of sealant is contradicted. Coming to the commercially available sealants, all major companies produce the typical brands of sealants. Like 3M, from the 3M we have Clean Pro. We have another one sealant with fluoride, that is HelioSeal F. Type 4 GIC is usually used as sealant application. It comes either as a capsule or in powder and liquid form. You can use it in partially erupted molars, or wherein the isolation is compromised. You can go for glass ionomer cement, glass ionomer based sealants. And there has been certain advancements in the field of sealants, like sealants that are free of bisphenol A and that releases fluoride after application for protection of the adjacent smooth surface has also been introduced. Conceal F is one among them. It is free. It's a resin-based sealant which is free from bisphenol A, and it can release fluoride after application. Sealants with remineralizing agents like amorphous calcium phosphate is available. The commercial name will be Aegis 5. And to monitor the sealant on further visits and to not to compromise the aesthetics, sealant that glows on application of visible light has been introduced. Color of the sealant will be confluent with the adjacent two structures until visible light is applied on it. Then it starts to glow so that we can monitor on recall visit whether any sealant loss has occurred. And resin-based sealant that can be applied even in situations with a compromised isolation has been introduced, which is called embrace wet bond. It does not require an etching and a bonding process, so that the amount of time that is spent inside the oral cavity of a younger child can be reduced. Sealing of pits and fissures of both primary and permanent teeth is safe and effective, both in preventing and the arresting of non-cavitated carious lesions. However, the long-term success is dependent on regular checkups and the renewal of sealing if required. Thank you.